what is the anatomy and a little bit of the function of the shoulder blade? You got two of them. They generally look like a triangle. There's three ends to them, right? There's a little spine that goes around the middle. But let's just start very basic. The superior angle. You've got a little bit of the levator. The levator is a very complicated one, but the top of the levator does start on the superior angle. Most of the superior part is covered by the upper trap. And then, of course, the supraspinatus up there on the north part too. Let's just go down to the spine, right? The spine of that scapula, usually at about T3, right? Supraspinatus on top, infraspinatus on bottom. Here's a fun tip though. At the end of the spine of the scapula, the delt hooks in on the bottom part of it, which is a good thing to know. And yeah, there's a little hole there. Then let's go over to the lateral side. The lateral side, there's one little tip that I learned a little while back. The long head of the triceps connects to the inferior portion of the
glenoid tubercle, I think.
Glenoid tubercle, yes. Good, thanks. I really should have written this down. We're doing it all from memory today. But the long head of the triceps, a lot of people don't think it does, but it actually does. One of the best postural stabilizers, long head of the triceps. Working down that lateral side, you got the teres minor, you got the teres major, and then on the anterior portion, you're talking subscap. Also very underrated muscle on the anterior side of that. Now we're going down to the inferior angle of it. We're working down to the bottom. The lats kind of cover the bottom corner of it. Where does that bottom? T7 generally, right? That's really all for the inferior angle. Then let's go up the medial border back around to the top. Of course, your traps or middle traps, lower traps are going to connect to the bottom of that. And then along the medial border, you're going to have your rhomboid major, and then going up a little higher, your rhomboid minor, and then more fibers back full circle to the levator scapula, all around the corner. Oh, and on the anterior side of that medial border, Bobby's favorite muscle in the whole body, the serratus anterior, connects all along that medial border and then goes down to like 9 ribs or something like that, over onto the lateral side. Then, what else? Oh, the acromion. Coracoid. Acromion and coracoid. Yeah. Dude, if this was like a class, this would be a great presentation. It'd be horrible. So then you've got your acromion, which goes out. Then we'll get to the coracoid. Acromion, 3 types. 1, very flat. 2, gets a little curved. 3, very hooky. The higher up you get, the more likely your rotator cuff is going to have problems, right? You tell me about the coracoid. I'm skipping all the ligaments. If you want the ligaments, find another place, because who cares?
Or the circumflex arteries and stuff. Yeah,
I'm talking about holes where nerves go through and stuff like that, right? What's on the coracoid process, though?
I think you go from medial to lateral along it. You got pec minor, and then you have the coracobrachialis, and then you have the short head of the biceps brachii.
There you go. We'll leave the clavicle, but yeah, I didn't get all the features of it, but
no, I mean that's most of it. I mean, you have I think the biceps brachii, also the long head feeds into the capsule and the labrum, but I think it technically attaches to basically the opposite of like the tricep on the back. It goes to like the supraglenoid tubercle, or just above the glenoid, but it blends into the capsule a lot. There's probably something we missed. I know there's a tiny bit of deltoid and upper trap maybe that attaches, not upper trap, but trapezius that touches the acromion or goes off the acromion. I mean, that's most of it. But I mean, I was happy with the coracoid. You tossed me the coracoid, because that's something that I feel is directly ties into the commonalities that you see a lot in shoulder pain or glenohumeral pain. And, we were talking a bit before we started about, I was saying the shoulder's super complicated. We talked to Dr. Offenberger a few weeks ago, and he was saying, the shoulder is complicated. There's so many things that contribute. But I was kind of saying this Pareto law says, 80% of these, in my opinion, 80% of shoulder cases can be kind of boiled down to just a few things most of the time. Right. Now, symptoms or symptomologies that come from a certain pattern. Now, you can have, for example, one would be like impingement. That's a very, very common reason to have shoulder pain. But, and as I'm sure John can go back into here, the reason why you impinge gets very complicated and is multifactorial. Just like, why do we wing? I don't think it's because our evolutionary ancestors were birds and we're just slowly reeling those in. I think it's and it's very, is it because of a nerve palsy? Well, that's totally different reason for why you wing versus whether the scapula is moving or the shoulder or the ribs are moving under the scapula. So just a little.
No, yeah, and I want to get into that. Before really quickly we get to where the important stuff, I mean, clinical stuff that'll help you in practice or help you in the gym, honestly. A little bit of the movement, a little bit.
Brachial plexus. You want me to break down the whole plexus?
That's it. Now, the development of it embryologically, we'll start there and we'll proceed to its roots and what happens month 3, what happens month 4. You're having a baby, you should know this stuff.
Yes.
Obviously.
Robert Taylor drinks cold beer.
That's right. Real Texans drink cold beer.
Real Texans, really? I don't know who Robert Taylor even is, but that's how I learned it.
A real Texans makes way more sense for the brachial plexus. Doesn't rhyme. Never mind. I tried. It was a reach. Okay, a little bit of the function. Really can't talk about scapular function by itself, obviously. Even if we're talking about just these muscles that are connecting to it, right? You have to talk about it in relation to the rib cage and or your arm, your humerus, the humeral action. And it can get incredibly complicated very quickly. But a couple of the basic movements, like we would talk about a femur or something externally and internally rotates, right? A couple of the basic movements. One of the baselines for human movement is respiration. And we're not going to go into this deeply at all, but in relation, we can relate that to, because that's a commonality between humans. We all breathe, Bobby. Just a fun tip for you. Tell your friends. On inhalation, the shoulder blade abducts, externally rotates away from the midline. It downwardly rotates and it posteriorly tips. Okay. This is like the general movements. Let's talk about, that was inhalation. Inhalation, abduction, ER, downward rotation, posterior tipping. Exhalation, opposite, abduction, internal rotation, upward rotation, and anterior tipping. Don't worry about any of that right now. The normal resting position, these are again some stupid numbers. Normal resting position, about 41 degrees of internal rotation, whatever normal means, right? 5 degrees of upward rotation, and about a 10 to 15 degrees of anterior tilt. That's kind of normal. So like if you're looking at shoulder blades, there'll be a general inspection. And we've seen this kind of on Instagram. People have a picture of a muscle bound back and they'll be like, what's the difference here on the left or right? And they'll have their arms move a little bit. And you can see like a scapula will kind of tip and be weird. You can notice differences on these sort of things, which is nice to do. It's a fun game to play. But like you want to know what is normal. Like, where should it normally sit? And people are like, well, your shoulder blade's tipping anteriorly. It should normally 10 to 15 degrees. That's normal. Some of the other little evaluation things that I think are a little bit more relevant in clinic, and then we'll get a little bit more towards the painful things. I think this is a nice progression here, are the angle between the clavicle, the acromion, and then the angle of the scapula, right? So if you kind of are looking straight down at a patient, right, from the top down, there's that angle, and it'll be a little bit of a triangle. I think Bill Hartman says it's a super helix because it can be twisted, the left and right ones, right? Got to make it more complicated. But if that angle from the clavicle AC to the shoulder blade is less than 60 degrees, you know that you're very decompressed and kind of elevated and really anteriorly tilted. But if your shoulder blades are kind of back and that angle's wider than about 60 degrees, you know you've got a fair amount of decompression in that area.
You said compression twice. So just the first one was compression, second one decompression, right?
Less than 60, compressed. Open,
yep.
Decompressed.
Got it.
Not tight, correct? There you go.
Yep.
And if it's also decompressed, you probably also lack cervical rotation to that same side. Sometimes you lack cervical rotation to both sides. And I'd be interested to see what you saw on like x-rays with this, because I know you used to take a bunch of x-rays. If there was a straight like pencil neck sort of situation, if you had or if you were compressed on both sides.
Mm-hmm.
Tests, how do you like to look at these sort of things?
As far as that angle goes, or are you talking about just the shoulder blade?
Just generally the functionality of just the shoulder blade, or even do you look at the shoulder blade in terms of function?
Well, I think if, evaluating something like scapular kinesia or like the movement of the scapula, to me is a bit akin to gait analysis. You can convince yourself of what you see, and you can convince yourself of what you see matters or doesn't matter.
Sure.
But I think it's only through some type of method, like methodology of testing and retesting, can you confirm that any of that stuff is important. And I mean, it's real easy to, get deep into the woods of checking somebody out and saying, well, they have this resting scapular position, and when they go overhead, I see that on the descent, it comes down too fast, and you're writing all these notes, and therefore I have to give them these eccentric exercises. And maybe it doesn't matter. It doesn't matter. If it's not related to their issue, who cares? And I think that's the thing you can take away from, like, tie it into gait analysis. Everybody walks different. Sometimes it matters, sometimes it doesn't. And if it doesn't matter to what their problem is, and they're not, gold medalist in gymnastics, then just let it go and see if it's even relevant. Right. So, I mean, I don't really look at necessarily the movement of the scapula. Static position, static position, I think doesn't always tell you a whole lot, but I think it does for shoulder blades quite a bit. So just shirt off, standing, tell them to relax, maybe take a few breaths in. That to me tells me a lot about their pattern compared to maybe how I see the shoulder blade go up overhead. Now, of course, I'm going to look in the region of their thorax when they lift their arms over their head, but it's got to be like glaring obvious for me to care. You know what I mean? So I just kind of want to know. I do like that resting static position, kind of like medial border to the spine. Are those different side to side? Mm-hmm. Is the inferior angle way different from the other side? And then going back up almost to that angle thing that you were talking about with Bill Hartman, like how does that look side to side again? Side to side is a big deal, because otherwise sometimes you just have people that are patterned in like a sagittal plane or bilaterally, and sometimes that's not always so bad. Like a lot of the research on hamstring strains in football players, America's soccer players, it says, if they're kind of tight versus somebody who's flexible, not a lot of difference in hamstring injuries. Yeah. But if you have somebody who has 45 degrees of straight leg raise on the left and they have 90 degrees on the right, that person is highly likely to injure something, because they are torqued. There's something going on if you are half the flexibility side to side. So I'm big on comparing side to side, first of all.
Sure.
I do stuff on the table, whether it's IR, ER stuff. I prefer I'll watch them do active shoulder flexion, but I like to do it on the table as well, like bracing the rib cage so I can control for some cheating a little bit. And I think Dr. Offenberger mentioned this a couple weeks ago too, like how people are amazing at cheating, and how if you don't use standard tests, he used the example of a wall stretch for hip extension. If you don't use something all the time, so you can spot these things, you actually lose the ability to distinguish what the patient's actually using to accomplish the task. So by, don't complicate your exam so much. Sometimes just be really good at the test that you do. You don't need 1,000 tests, but maybe you're just very good at feeling a few tests and you do them. So, I do my IR and ER and my flexion, and Do some rib cage and sternum kind of movement assessments, respiration assessments, a little bit of T-spine assessment, cervical rotation and side bending and lateral flexion, stuff like that.
Yeah.
And also a little bit of pelvis stuff, because that can tie up the chain, of course. So that's kind of your foundation for your upper half. So that's where I go.
Yeah. No, the only thing I'll add to that is like the passive IR, ER, abduction. I think a lot of people do shoulder flexion tests, and I don't think they do them very well. I think a lot of people have their patient lay on the back, and then they grab their wrist and they just lift it up overhead, and they're like, look, okay, cool. Shoulder flexion's cool. So like, even when you said just a second ago about, at least bringing the ribs down, or at least holding them down, because you can get that rib flare to pop up. And now we're not flexing the shoulder, we're extending the ribs, right? So like, one of the things I really like to do to keep things specific for me is to grab them by the elbow, kind of medial lateral epicondyle, try to keep their olecranon process in the sagittal plane, keep their ribs down, and see how high that olecranon process can stay, whatever the sagittal plane means, straight up and down, let's just say, before they internally or externally, if they externally rotate, then that's messed up. When they start to internally rotate as they flex, or I really feel those ribs start to push up. And I bet if you started to kind of keep those ribs down and keep that olecranon process, that elbow going straight up and down, I bet you might find a few more limitations in the rib cage. Just as a rule of thumb, if the elbow doesn't get above 90 degrees, and these are for some people who practice a very particular way, you could probably assume below 90 degrees, they have a problem in posterior expansion below the shoulder blade. So below 90, below the shoulder blade limitation. Around 90 degrees, give or take, is going to be mid shoulder blade, T7, T3. And then if the limitation is further up and they can't get all the way into full flexion, then most likely there's a posterior compressive strategy they have, T4 and up somewhere. And that's pretty common too on that same side. That's just one silly little tweak I like to do every time. It helps me a lot to find those kind of little gaps. But I do think, the shoulder tests are done. Even if you just do them active, there's so many cheats. Like if the arms are up overhead and I see people, one arm is straight and the other elbow can't bend, I know that those triceps are a limiting factor. Little things like that. And so simple interventions like getting a couple tricep extensions with full extension, or simply a lacrosse ball, depending on the conditioning of your patient, can help that overhead movement to get a little tricep stuff.